Today's Kin Ed involves surgical cricothyroitomy. Your indications are a rescue airway for failure of intubation, ILMA, or BVM in a patient who cannot be oxygenated or ventilated by any less invasive means. It can also be in the case of need for a secure airway in patients who have oral or nasotracheal intubation would be impossible, such as a gunshot wound to the face with severe lower facial trauma. Your contraindications would be the ability to adequately ventilate and oxygenate a patient with either the intubating LMA, your BVM with an airway adjunct, or a properly placed endotracheal tube, as well as children of less than 12 years of age. For the procedure, you need to gather all the necessary equipment. You're going to prep the neck with betadine, cleanse the area. Then you want to locate your landmarks, your thyroid cartilage, your cricoid cartilage, and your cricothyroid membrane. And you're going to grasp the thyroid cartilage with your thumb and long finger of your non-dominant hand. At that point, you're going to make a 2 centimeter vertical incision directly in the midline over the cricothyroid membrane. No, it needs to be a scalpel. Okay, so we want to make a 2 centimeter vertical incision directly in the midline over top your cricothyroid membrane. Next thing you want to do is you want to make a horizontal type stab incision after you have approximated again your cricothyroid membrane. So once you've found that, you make your horizontal stab type wound. Next thing you want to do is you want to insert your tracheal hook through the incision and rotate it up towards their chin. Okay. Next thing you want to do is hand that off to your partner so that they can maintain traction at that point for you. The next thing you would do is you want to insert your trousseau dilator through the membrane incision with your non-dominant hand. So I'm going to, purposes of this, going to take the hook out. But again, normally that would stay in place. So you want to fully open your dilator at this point. And you want to insert your Shiley trach into the incision site. Okay, and you want to rotate both your dilator and your Shiley trach towards the patient's feet at the same time. But you can insert your trach as you are rotating it. Tracheal hook will stay in throughout this whole time. So you want to take your trousseau dilators out, take your obturator out, put your inner cannula in, and then inflate your cuff and evaluate to make sure that the trach is in proper placement before you take out your tracheal hook. Once you verify proper placement, then you can take your tracheal hook out. If your Shiley trach does not work or you don't have one for any reason, you can also use a mid-size ET tube, say like a 6.0. Just make sure that you confirm your tube placement and that you can adequately ventilate the patient afterwards.